Okay, we'll go ahead and get started. Welcome everyone to Faculty Research Lightning Talks. Thank you for joining us this morning for our virtual Lightning Talks. For those of you who may have participated or attended Lightning Talks in the past, we've been doing these for about the past 3 years, but this is actually our first faculty session of Lightning Talks. So I'm very excited to present two OU-Tulsa faculty members today to present their research. We'll also have one vascular surgery fellow who was unable to join us yesterday for the student, resident, and faculty talks who will present after our two faculty members. If you've never attended a lightning talk before, the faculty lightning talks are going to have a little bit different structure than our talks yesterday. Our faculty members will have 10 minutes and 10 slides to present their research. So without any further ado, I'll go ahead and get started. Up first, we have Katie Prentice, who is the Associate Director of the Schusterman Library. And let me hand over control of the screen to Katie so she can progress her slides. Oh, and got it. You got it? Okay, great. Let me get my timer out as well. For our presenters, I should have given you a heads up. I'll be flashing a 5-minute, a 3-minute, and a 1-minute in the video so that you know where you are in your talk. Just one moment. All right, Katie, I'm ready for you whenever you are.
All righty. Well, thank you very much for coming today. I'm excited to tell you a story. And I didn't know when I started this project last year that infectious disease would be such a popular and terrifying topic right now. And so I'm sorry for the scary bits. Normally I talk to librarians, and so this is a lot more fun for me. So this whole story started for me last year, and I'm going to talk specifically about bibliometrics and how articles are tracked over time. So if you're unfamiliar with this, bibliometrics is the use of statistics and study and numbers, lots of spreadsheets to track the relationships of how things are published and their topics and sometimes newsworthy events. And most of you are familiar with the idea of and practice of open access publications. And this is a change over the last, I guess majorly in the last 10 years, where articles are no longer, many of them are not behind a paywall. They're freely shared online with everyone in the entire world. The important disclaimer here is that we're going to talk about disease, we're going to talk about publications, we're going to talk a little bit about ethics, but I'm not a doctor or a lawyer or an epidemiologist. And so I'm going to tell you this story and how I discovered this pattern because one day I was angry at the internet. So let's keep going, maybe. Okay, so many of you are familiar with the disease Ebola. It was actually first identified in 1976 in Central Africa, and you can see that section there in the map. Those are the countries which are today known as the Democratic Republic of Congo, Uganda, South Sudan, Gabon, and this is, I guess, an example of one of the diseases that was named based on the location where it was found, which is something that we traditionally don't see anymore because it was discovered near the Ebola River. In 1976, it was a big outbreak, and periodically since then, additional outbreaks have been seen. But in 2014, a major outbreak occurred in West Africa. And you can see those countries are labeled. We have Mali, Sierra Leone, Liberia, and Senegal, and a few others. And this big outbreak was something that the rest of the world experienced too because of air travel. People traveled all over the world. We saw small outbreaks as a result of this in many other countries. But this major outbreak was huge. There were over 28,000 cases that were both suspected and confirmed, as well as over 11,000 deaths. And because of this big change, because it was so different than the previous outbreak, a lot of research has been written about it in the past. And so it's been a while. 1976 to 2014 was a major change in time as well as science and publications. And so that's where this story begins. Last summer, while I, like many other people, I scroll through Twitter, I watch the internet, I follow a few people online who talk a lot about publications. And someone I know retweeted this tweet from July of 2019. And what the person on Twitter said was that that there was a powerful example of the importance of open access. And this was, of course, July 2019. And they linked to an article from earlier in 2015, which was an op-ed piece in the New York Times, which you can see here. But on Twitter, they said that we knew about Ebola in 1982. And I'm like, well, okay, yeah, everybody knew about Ebola. But then they went on to say that research was locked away in Western journals and that this is a result, people died. And I thought to myself, as I'm scrolling through Twitter on my phone, I was like, well, that doesn't make any sense. 1982, publications were pretty traditional at that point. So I clicked through to the article in the New York Times. So was a few years old at this point. And it was an op-ed piece by local health officials in Liberia in Western Africa. And they maintained that there was not a lot of local knowledge about how much Ebola was present in society at that point, and that as a result, this led to a larger number of deaths in the outbreak at that point that they're writing was ongoing. And so at this point, I was, my librarian hat turned on. And I realized, I was like, well, wait, what are they talking about? And so when I got to work, I will admit to a little bit of rage at this point. And I spent a while trying to track down this article that they mentioned. And so after quite a bit of effort in Web of Science, Google Scholar, I was able to pin down the article itself. And so it is actually from the Annals of Virology of the Institute of Pasteur, a serological survey on viral hemorrhagic fevers in Liberia. And this top part there is a screenshot of the article itself, which I had to request through interlibrary loan to get a copy of, because it's not a journal we have in our library. And with a little bit more work at this point, I also was able to finally find the article itself in Web of Science, but notice it has a different journal name listed, the Annals of the Institute of Pasteur Virology. And at this point, I'm thinking, well, okay, it's no wonder nobody could find the article, because it was just super hard to find, and it was from 1982. So this kept me going. I'm like, all right, well, what does all of this mean? Could this article have been the secret to saving lives? And so I read the article. All three of the authors were from what was then West Germany, Hamburg, which is the Bernhard Nocht Institute for Tropical Medicine. Makes perfect sense that they were studying Ebola. The study described 433 participants who were randomly found, according to the article, from Liberia and the surrounding countries. They asked their participants to describe 5 years of movement. They did not describe their informed consent process in the paper, which is something we would look for today. But it concludes with this really telling sentence. Therefore, medical personnel in Liberian health centers should be aware of the possibility that they may come across active cases of Ebola or Marburg, and thus be prepared to avoid nosocomial epidemics. So they're not underselling the identification of the antibodies of these two hemorrhagic fevers in their articles. They also presented it at a paper in Nairobi in 1980. It presented the paper in Nairobi, so they weren't hiding it. So what does all of this mean in the context? As a journal, it was not hidden. They didn't hide it. They maybe didn't make the best choice, but this journal is, on the print copy, was different than what I found. Even Google Scholar listed something even different from them, but I was able to identify 33 citations from 1984 to 2020. And if we're thinking, well, wait, when was Google Scholar released? It came out in 2004, so we've come a long way. The journal has changed names about 9 times since then. And so it wasn't a conspiracy. It was definitely just hard to find because of the journal and the citations itself. So when you look at the citation patterns of Ebola overall, you can see that the publications came from the very beginning to the epidemic, and the red lines show how many papers were published that specifically mentioned any of the countries in West Africa, and the green line is overall publishing on Ebola. And so you can see that this, of course, peaked during this epidemic, and you can see in the bracket which years were the major outbreak, but there were quite a few articles, that started in the 80s and then in the 2000s about West Africa itself. And so looking at all of that, the idea that maybe it was hidden overall, well, there were many countries that had it covered, from which the papers were published. You can see that, of course, the United States, England, but as well as Sierra Leone, Liberia, the Democratic Republic of Congo. These were not entirely Western publishers and authors that were writing about and citing specifically this paper. So what that says to me is that the paper was findable and it was not entirely hidden. You could say that maybe they didn't make the best choice on where they published it. They also didn't have a local partner, which is something that in community-based participatory research methods we would see today. Open access was not the thing that led to anyone not finding this paper, because in the 1980s, open access was writing a letter, pre-email, to an author and asking for a copy. It was probably hard to find because it was a small journal. It was not indexed then or now in PubMed or Medline, so you can't find it easily except through Web of Science or Google Scholar. And so, there were some definite problems. And when we fast forward to today and we think about open access and what that means, we are again engaged in a global epidemic. And as of March 3rd, there were over 2,000 articles just on COVID-19. And I checked this morning, there are 3,587 articles that talk about some variety of COVID-19 or coronavirus just from 2020. And so as you think, where will I publish my articles on any topic? The journal that you choose matters, because where it's indexed matters. How will people find it? And we're going to find out soon that a lot of these articles and they'll end up withdrawn. They're not going to be accepted by the journals in the end. And so I would encourage anyone who's thinking about publishing on any topic to, check with their librarians and see where is that journal indexed? How long has it been indexed? How will people find it? Because it's the tree falling in the forest. If no one reads your article and cites it, did it actually happen? And so I'll end there with the reminder to wash your hands and check with your friendly librarians when you choose a journal. Thank you very much.
Thank you, Katie. So we do have a couple extra minutes since we have fewer presenters today, so we'll take a couple of questions. We received one through chat, and our question asker is asking, what are things restricting better uptake of open access? Do you think that the economic costs, like university budgets, et cetera, and the intellectual demand stemming from COVID will lead to improved open access publications?
Well, that's a great question. I think in some ways it's two parts. One of the biggest obstacles right now to open access is actually tradition or public opinion. When you talk to a department or other professionals, they think, oh, we don't want to be in open access. We want to choose a traditional journal because people will find it. Except that if you look at studies on open access, an open access article is more highly cited. So the other half of that is then how do we make good choices and then not have the economics get in the way? And I think this is where all of us who can serve on editorial boards or even start our own journals, we can say, you know what, we're not going to start a journal, or I'm not going to participate in a journal where they want $5,000 from me just to get my article. Maybe there's a submission fee, sometimes there's a publication fee. And I think the answer is no. We need to tell those journals that that's not an acceptable choice. We can start our own journals, we can form editorial boards and use the same, free labor for peer review and these other processes that we're giving to the paid journals anyway, and then choose not to charge those fees. There are some also journals that charge reasonable fees, not into the thousands of dollars. Where we can do that. And I think, maybe the next question is that your next big meeting, when we get to meetings again, talk to your colleagues about, maybe we should start a journal. Many of our universities host open access journal platforms. And so all we need is a plan and a group of people to come together. That's a very long answer to that question, but it's something I get excited about.
No, thank you for that answer. And if anyone else has any questions, I'll give it a minute to let you pop in the chat or just unmute yourself and ask a question. Okay, well, thank you very much, Katie. Up next, we will have Dr. Sherri Castle, who is the Assistant Director for Research at the Early Childhood Education Institute. And Sherri, I'm going to go ahead and give you control of the screen so you can progress your slides.
Okay, thank you, Alyssa, and thanks, Katie, for your great presentation. Good morning, everyone, and thank you for joining. So as Alyssa said, my name is Sherri Castle. I'm the Assistant Director at the Early Childhood Education Institute. If you're not familiar with the ECEI and our work, I wanted to just kind of quickly say that we conduct applied research in early education settings, most often with children from about 6 weeks of age to 5 years old. The data that I'm sharing today are from our program evaluation and research partnership with CAP-Tulsa. And CAP-Tulsa, you may be very familiar with them. They're a local anti-poverty agency, and they are also a Head Start, early Head Start provider here in Tulsa. They serve about 2,000 children in their programs every day. Unfortunately, they are also currently closed, so they're grappling with all of these changes as much as we are. But we have data from prior years that we're still analyzing and learning from. So the data I'm talking about today really focus on 3- and 4-year-olds. So that means that they are either 1 year or 2 years prior to kindergarten entry. See if it will move for me. Okay, there we go. Okay, so for those of you, just to provide a little bit of context, in early childhood, we talk a lot about the achievement gap. And without intervention, children who grow up living in poverty or are otherwise disadvantaged would show up to kindergarten well behind their more affluent peers. So they would show up with lower levels of school readiness. And so decades ago, the federal government designed Head Start programs, which provide services for 3- and 4-year-olds to boost their school readiness so that they can be more prepared to learn and not fall behind from a very early age. So our field of early education has been studying this context, and we've noted that early care and education programs are quite impactful in protecting children from the risk associated with poverty. So we have lots of evidence showing that children who attend these programs enter their classrooms at kindergarten more on par with their affluent peers if they've received high quality early education programming. Through the research over the last couple of decades, it's been identified that there are various features that have been studied, things like teacher degree, teacher level of experience, ratio of children to teachers in the classroom. But what's really been identified as the active ingredient driving the impacts on children's outcomes is teacher-child interactions. So that means the ways that the teacher interacts with the child and provides a warm, stimulating, enriched environment for the child to feel safe and secure, and also to be able to learn. So that's what we really dig into focusing on, is the teacher-child interactions, and trying to understand, in partnership with our friends at CAP-Tulsa, what's happening in their classrooms and what features might we want to increase happening more or change a little bit about it's happening, how the things are currently occurring, and the coaching that we can partner with them to provide to their teachers to continually improve the services for the children. So right now, the way that the assessments have been done for the last several years in our field has some methodological limitations, and it's hampering our ability to provide strong, clear recommendations to the field as to how they want to invest their money to better coach and support their teachers. So right now, the field really focuses on a couple of measures, and we talk about global child care quality or global early care and education quality. And so in these measures, we have some problematic assumptions. And what that stems from is that the scores are assigned at the classroom level. So there's one measure called the class, which is widely used and is part of our federal evaluation of Head Start. Scores are assigned at the classroom level. So for instance, in these pictures, our assessor, our observer, would visit the classroom and they would watch for 20 minutes and they would assign one score, ranking the amount of language modeling that's happening in the classroom. And that score would be based on the experience of the average child, is how the manual describes it. And that means overall, how are the children experiencing this classroom? But a problem with this is that not all children experience the classroom in the same way. So these pictures that I have on the slide here depict a little bit about just little snapshots of how you can see that this assumption that one score can adequately represent all children's experience in the classroom is limited and a problematic assumption. So if you look here on the left, we can see that this teacher appears to be, enthusiastically, probably singing or talking with the children. And you can see that some of the children are looking at her and are engaged in that interaction. Whereas you can see that a couple of children, this child here on the left is playing with their fingers and just kind of looking downward and not really benefiting from this interaction. We see another child over here who's also gazing, away from the teacher. And again, on the right, we see a similar thing. We see some children who are possibly engaged with the interaction and others who are not. So we would not expect that a single score could represent each child's personal experience in the classroom just within this little snapshot of a moment. And this is replicated over and over and over again throughout the day. So we've been working on using some newer tools to be able to assess this, deal with this problem. So the teacher-child interactions, they do predict child outcomes, but the association with our global scores are weak. Currently, the variation at the child level is just sort of thought of as noise or measurement error, but so it's just ignored. But that within classroom variation is likely not random. So there's probably some reasons why children might be having a more or less engaged or more or less beneficial experience than others. But most studies currently ignore that variation. So in our study, we had observers visit the classrooms to collect detailed data about individual children's experiences with teachers during a typical morning. We were there for about 4 hours, and our observers, we used a measure called the COP, Child Observation Protocol, or Child Observation in Preschool, and we observed each child for 3-second scans, and then would cycle through all of the children in the classroom, watch each child, code a number of variables about that child's experience, and then move on to the next child. And gathering these repeated measures throughout the morning allowed us to create aggregated scores for each child's experience. So this is just the very beginning look of what we've been doing, just some descriptive thinking and analyses of what children's experiences might look like. And then we're continuing to dig into the data to try to see, does this explain to us why some children are not demonstrating the growth or the response to the intervention that we might expect? So here, this figure is showing, we're looking to compare children whose home language is English with children whose home language is Spanish to see if there seems to be meaningful variation among those two groups. So we found that children who speak English at home were more likely to be seen talking in English than talking overall and also talking in English compared to their peers who speak Spanish at home. We also found that children who speak Spanish at home are just more likely to be found not listening or talking in a given scan. So there's just having less interactions overall. We also found that children who speak English at home demonstrated slightly higher levels of positive engagement, although we didn't find a difference whenever we look at codes that really captured disengagement. So it seems that children who speak Spanish at home maybe are just not being pulled into the highest levels of engagement. Similarly, we didn't see any differences in child involvement though, so that was something that was encouraging to our partners to see, because we're really just trying to parse apart what are the features that children are experiencing differently, and where is the program working pretty reasonably well. So the children are involved. Whenever we look at their involvement in the activities, this code is really capturing, does the child seem to be actively engaged in the work? And we didn't find any differences there. And then finally, just one last little slide here, or figure. Whoa, it's moving on its own. So I don't know why it doesn't want to go back. Okay, so here we were coding for children's engagement in a subject-focused activity. So this is where we could identify a subject that, like a content area that they were focused on, math or a literacy activity. And we didn't find any differences between the children who speak English at home compared to the children who speak Spanish at home. We did, however, find some difference in that Spanish speakers were observed spending less time in social interactions, as well as more time in non-academic interactions. So in the non-academic interactions, it's where we're just sort of not able to identify any substance the child is really engaged with or about. So these are early indicators that perhaps some of our dual language learners in these early education classrooms are not being adequately pulled into the classroom activities, and especially not being given opportunities to practice their language skills. But we did find overall just kind of mixed findings so far regarding these home language characteristics predicting their children's experiences. We did find some evidence that there were differences by home language, and that they may need additional opportunities and support to practice their English skills. So some of our next steps include digging further into that to see, our program partners are interested to see in the different contexts that occur in the classroom. What about if we look at small group activities? You know, does that provide a safer opportunity for children to practice their English skills? And if so, they can help their teachers shape their classrooms in a way that's more supportive to the dual language learners. We also want to be looking at other predictors of individual experiences, including child race, also special education status or mental health referral status, and also looking at if children who enter the classroom with lower levels of skills are experiencing different interactions and different experiences in the classrooms overall, which may or may not. Hopefully that would help us explain and better understand why some children might not be responding to the intervention as anticipated. So we have lots more work to do, and we are excited to share these early findings, and we'll be looking forward to sharing additional findings in the future. Thank you.
Wonderful. Thank you, Dr. Castle. And again, sorry, I'm trying to get your slides back. Again, if anyone has questions for Dr. Castle, please unmute yourself or pop your question in the chat box, and I will be happy to ask. All right, and while we're waiting for questions, I'm just going to transition our slides to our next presenter. All right, well, thank you so much, Dr. Castle. We appreciate you presenting with us today.
Thank you.
And we have one more presentation today. Dr. Viraj Pandit was unable to join us yesterday for the the student, resident, and staff lightning talk. So he will be presenting with us today instead. So we're so delighted that you were able to join us for this additional presentation time. So I'm going to go ahead and give Dr. Pandit control of the screen. And this presentation does have a slightly different structure than the faculty presentation, so he'll have 5 minutes to present.
Good morning, everyone. Thank you for the privilege to present my work today, and sorry couldn't present it yesterday. So I'm a vascular surgery fellow at OU and would like to discuss about a curious case of a surgeon scientist. As we all are involved in research, there are multiple motivations to do research for an undergrad student, as a resident, as an attending. But I think the thread which joins among all of us is to make a difference in the patients that we treat, to make a difference in the communities that we are involved in. And I think the importance of research spans across these motivations. So just to understand what motivates everyone to do research and how can we do research and simplify research for our students and our residents to help them reach and achieve what they want to achieve. So this is the data about medical from the AAMC about medical school admissions, and this is from the year 2018 and 2019. And as you see, even students enrolling into medical schools, there's been an increasing rise at an undergraduate level for people involved in research to help them get into medical school. And there's been increasing enrollment of students in MD, PhD programs. After you graduate from medical school and you get into residency, this is more about just general surgery residents, but and looking at programs based on how they enroll residents, as you can see, after your scores of your US MLIs, there is the most important thing which makes difference between your enrollment to a higher surgery program or a mediocre surgery program is your difference in research. The students who are more likely to get into Ivy League programs, who had more research publications as well as presentations. And not only in general surgery, if we look at across specialties from internal medicine, psychiatry, orthopedics, there was a significant difference between residents who matched and who did not match based on whether they had experience in research in terms of their ability to publish or present. And then research not only helps you achieve your goals in your academic proficiency and even after you become a fellow or an attending to help your progress, but also it helps even in your education. That is, when you're a part of research, that studies have shown that involvement of research in your residency curriculum not only helps improve your clinical practice, but also helps to develop skills and critical thinking, which overall improves you as a complete physician. And so it's just not about getting another publication or another grant, but it's more about helping you develop as a complete trained physician. And that's what research helps you. And beyond that, it most importantly helps to make a difference in your patients. Now, the biggest question for anyone wanting to do research is, I don't know where to start or I don't know how to begin. And I think the first step to start doing research or getting involved in research is mentoring. Finding that one mentor that can help guide you through these puzzle waters to help motivate you, to help advise you, who has the same alignment up with your goals and helps you in the right direction to achieve those goals and trains you. And I think that's the biggest concept. And this mentoring leads to a development of a team of you, your mentor, and then other team members like other residents, fellows, statistician, the librarian, the medical school editor, and everyone. So that's a key component. And the basic principles are the question, which can come from your day-to-day practice, a question that you can see in your clinical practice, the question you can arise when you're talking to people, and now in the social media world and Twitter can give rise to a question that is your hypothesis, and you can build on that hypothesis and then help design a study and go from that to your data analysis, where again, your teamwork helps a lot. And then everyone has the biggest question is, I don't know how to write. So the best thing to do is just start writing. Write down one word. That one word will go into 3 sentences the next day. 3 sentences can develop into a paragraph, and you can build on that, and within no time you'll have a manuscript. And again, having that teamwork and that mentoring can help you design and develop this manuscript. Like I started, the most important thing about research is, one, to realize the clinical problem that you're facing in your day-to-day activities, be it in the communities that you're dealing with, the patients that you're dealing with, and then evaluate the care that you're providing and how you can improve that care, because everyone at every stage thinks, oh, I can do better and help provide better care for whichever aspect you deal with. Then help to strategize an optimum care plan, involve in surgical practice, and then help to advance the practice of medicine in whichever field that you're doing. Most importantly, research helps also to improve your clinical understanding, not of only a particular disease process, but about your overall clinical improvement. Help to challenge the current dogma. It's not that if you've been doing one thing for years, we have to continue doing that. We can always improve on that. And I think the most important reason why you should do research is to help make a difference in your community, a difference in your patient care, and a difference in the people that you deal with on a day-to-day life. So thank you again for the opportunity to present, and I'll take some questions.
Thank you so much. Yes, if anyone has any questions, please feel free to unmute yourselves or pop your question in the chat, and I will be happy to ask it for you.
I'll ask Viraj a question. This is Peter Nelson. It's probably unfair because I'm his program director, but I think it's important. Viraj, tell everyone how you are actually following through to get students more involved in the research that you're doing.
Thank you, Dr. Nelson. So I've been here now for 7-8 months, and we have had a vascular surgery research interest group and a surgery interest group through which I've in contact with multiple students. And to mention a few is Joshua Chintwood, Kelsey Babb, and many others. And through them, I've been introduced to many more medical students, from first year to even third, fourth year medical students, who have been involved in wanting to do research, but don't have an avenue or the thing which I mentioned, the concept of mentoring. So our division, Dr. Nelson, Dr. Kemp, and Dr. Kim, and everyone else have been helping to mentor these students, and I help achieve their goals in terms of trying to, navigate these waters of doing research, from where to start and aligning their goals up to the end, be it helping them match into a surgery program, helping them make a difference in the community, or just learning the basic of research. And again, it's not that if we only help in you trying to get into surgery, be it any field of medicine. I think the core reason to do research is, like I said, is to make that difference in patients and to help improve the patient's care.
Great, and we had another question pop up about what are, if there are any required research components for the vascular surgery fellowship or for the general surgery residency.
So there is no prerequisite in terms of having research, but matching into any surgical program or any program for the matter, nowadays, research has become a critical component. Not because they want you to, publish or help the program, but I think to assess you as a complete physician, and you having that background to build on is important. Not only to do research, but also to understand research, because as most of the medicine that we practice nowadays is evidence-based medicine. So it's important not just to help understand those research too, to understand, oh, this treatment, though this paper looks good, it's not that great actually. So it's important not just to do research, but understand research. So there are no prerequisites, but any amount of research, be it a case presentation or even a case report or a poster presentation like we had last week, I think all that adds up, and it's definitely important.
Wonderful. Thank you so much for your answer, and thank you for being able to join us today and present your research.
Thank you again.
Yes, thank you. And thank you to all of our attendees and presenters who are able to join us today. Presenters, we appreciate your flexibility to tackle this new virtual presentation format. And attendees, we greatly appreciate that you were able to join us today. And we hope that you've enjoyed these Research Week events so far this week. And if you haven't had the chance yet, I will give one more big ask to please check out the Research Forum posters. I will put that link in the chat for everyone one more time.
And this is Kent Teague. Thanks everyone, including especially the library and the library staff and ORTSA for being so flexible and making this Research Week actually still happen with everything that's gone on. So really appreciate everyone presenting and everybody working on this, President's office and the SCM Dean's office both. Really nice job, everybody.
Thank you, Dr. Teague.
Great. Thank you, everybody.
I agree. It's a wonderful job. Great. Invigorating. Shows how adaptive we all are. You all are.
Thank you.
Good. You're welcome. Thank you.